Hello, everyone. Thank you for joining us for the Let's Talk Overdose conference, Shortcut to Survival for Adolescents and Young Adults. My name is Kovia, and I will be moderating this lightning talk session. Just before we begin, I'm going to give a brief overview of the structure of the session. We have 4 presentations scheduled today. Each presentation will be 5 minutes long and will be followed by a 5-minute question period. You can ask questions through the dialog box that is on the bottom right-hand screen of the Whova platform. We recommend submitting your questions during the presentation or right after the speaker has finished presenting. If you like a specific question that has already been asked in the Q&A box, you are welcome to give it a thumbs up, as we will be selecting the most liked questions first. Also, stay tuned. There will be an award for the best presentation, so please vote for your favorite talk in the poll that is also located in the Q&A box in the right-hand side of the Whova screen. A winner will be announced at the end of the conference, and the winner will receive a certificate, free registration to a future conference, and an invitation to present a workshop at a future conference. Lastly, we encourage all speakers to stay for the duration of the presentations. Let's begin. Our first presenter is Stephanie Polderman. Stephanie is completing her medical degree at UBC, and Stephanie is interested in learning more about interventions for individuals with substance use disorders. Stephanie will be talking about the prevalence of nitazene in the North American drug markets. Everyone, please welcome Stephanie.
Hi there, everyone. Yeah, sorry, my video is not able to turn on here, but hopefully you can all hear me. And I'm not able to see the slides yet.
Yes. So I'll share the screen whenever you're ready.
Oh, awesome. Yeah, I'm ready. If you guys are okay with me not having my video on.
Oh yeah, that's perfect. Okay.
Okay, great. You can enable it if you'd prefer, but
okay. I'll do it now.
all right, so hello everybody. My name is Stephanie Polderman. Please stop me if you can't hear me properly. This is a perspective piece titled Making the Fentanyl Crisis Even More Dangerous, Nitazenes Hitting the Streets in North America. Please see my contact information below there. So here's a small subset of our team who worked on this project: the esteemed Dr. Michael Krause, BC Leadership Chair in Addictions Research and keynote speaker at this conference, myself, a future R1 at UBC Anesthesia, and then Suet, assistant researcher in our group. We're a part of a large, wonderful group called the Addictions and Concurrent Disorders group. And if you take anything away from this talk, that would hopefully be that nitazenes are dangerous contaminants in fentanyl, putting people at risk for increased mortality. As Dr. Krause likes to broaden our perspectives, it's important to look at these things with a global context first. I like this quote from the World Health Organization that there's multiple ongoing opioid overdose epidemics in the world, one being driven predominantly by fentanyl in the US and Canada, and the other by tramadol in North and West Africa, the Near and Middle East, and Southwest Asia. So this graph shows the illicit drug toxicity deaths in BC. Most people at this conference are aware of the unprecedented mortality. The number of illicit drug toxicity deaths in November and December 2022 is about 6.4 deaths per day. An important contributor to this is the increasing primary use of fentanyl, which this graph shows that increasing primary use, except for it associates it related to death. So this was 86% in 2021 in BC, and often people who are buying fentanyl are unknowingly using other substances such as synthetic opioids, including nitazenes. So why do we care about nitazenes? Between July 2020 and August 2022, etizolam, a nitazene, was found in 35% of the illicit drug toxicity deaths that have undergone expedited toxicology testing. A little bit about nitazenes. They're mu opioid receptors studied in vitro. There's many unscheduled members. There's no approved medical uses currently. There's some use in research, and some of the street names, although I haven't heard it myself, are ISO and pyro. So why do we care that these are contaminating fentanyl? Because the sum of the individual parts does not equal the final risk for mortality. So in conjunction with other substances, these can be extremely difficult to detect and cause increased mortality together. So this graph is showing the different types or subsets of nitazenes detected on the market in Canada. The first known appearance in Canadian markets was in March 2019 in Alberta. Europe around the same time, US later that year. It's present in the UK and Australia, and recently the first cases in Japan and Australia. So it's extremely difficult to detect. It cannot be detected by fentanyl strips nor urine drug screens. Even point of service checking is extremely expensive and low availability, including mass spec and liquid chromatography. And on to my conclusions here. The contaminants in fentanyl are increasing for nitazines. Mortality is unprecedented, although we see that little dip in 2021. Specifically, nitazines have an increase in overall detections of samples by fourfold from 2020 to 2021. They have an unclear pharmacological profile. They have high lipophilicity like fentanyl, and the ranges of potency go from 20 times stronger to 50 times weaker than fentanyl. Naloxone efficacy is unclear. People who use nitazines are unknowingly at higher risk of overdosing, and contaminants can create mixed vital signs. We do have handheld portable Fourier I can't even say the word, it's so complicated, to test the nitazines in the samples, but the actual cost, efficacy, and accuracies are being explored. And we do have 95 new treatment beds starting at St. Paul's. Onto our discussion here. I'm a little bit behind, but I'm sure you guys can read this. Is this really a problem that needs to be addressed? We need to evaluate the cost and resources for deaths versus detecting these drugs. Where are they being produced? Some customs seizures indicate China. Why are they being produced? There are trends based off of scheduling different classes and banning classes of drugs, as well as how COVID has been affecting tighter restrictions. What do we need to do? Obviously, we need some increased harm reductions in BC. We have fentanyl powder programs. We've got increased testing available, which we're hopefully increasing as well. And we're using chromatography and mass spec. My personal experiences on the addictions ward is that sometimes patients who are using contaminants are not aware of what are in their substances or the risks and harms. An Australian case report I saw had described how the patients were actually aware that they were using different nitazines, yet were still at higher risks due to the various subsets and high toxicity. So what happens when naloxone doesn't work? We need medical support and training for multiple doses and recognizing unclear overdose pictures. We need more socioeconomic supports, and safe supplies are a huge part of the picture in the overall treatment plan. So here are my references. Please contact me for any questions, and I'm here to learn the broader perspective on addiction medicine. And thank you all for listening and sharing your own expertise and experiences.
Thank you, Stephanie. That was a very insightful presentation. I'm just going to quickly check if we have any questions in the poll. One moment. Okay, I have a question. So is nitazine and fentanyl consumption happening within the same population demographics? Meaning, is there some sort of an overlap that we have observed or any trends in that?
Yeah, so I think the main trends that I was trying to harp on there is that we are having increased primary fentanyl use, so people using fentanyl as their primary substance. And then we're seeing that the increase in contaminants, known or unknown, in that fentanyl are nitazines. And so the various different classes, I think I quoted the one atizolam was 35% in the recent toxic drug supply. Yet that is only a tiny subset of what we're actually able to elicit of these different contaminants in the drug supplies, because they're so difficult to test for and take so many resources. So my guess would be that, yes, this is the same population that are using fentanyl. I know that we do have safe supply of fentanyl powder programs, et cetera, but from personal experience, and I'm sure I'll learn more today, those can be sometimes difficult to access and sometimes not meet the needs of our particular populations. So I don't have any data to support that, but overall my guess would be, yes, these are the same populations being affected.
Amazing. That's a great answer. Thank you so much. I'm just going to see if we have any more questions. Yes, I see a question. How does nitazine compare to xylazine? I don't know if I pronounced that correctly.
Yes, if whoever asked that question, I just forget exactly. I think xylazine is a tranquilizer. Yes, I just learned about this. So it's, I think the street name is trank dope. I believe it is a completely different class of drug. It's a veterinarian drug typically used as an emetic in cats, et cetera. Oh yes, it's a clonidine. So it is a totally different class of drug, but how does it compare? From my small personal experience on the addiction wards, it's another unscheduled class of substance that patients can often not be aware that is in their supply, or sometimes they are even aware, but they don't realize sometimes that this is not giving them the desired effect, or they're at a higher risk of respiratory depression and mortality. And so how I would say is that they compare is that they're in such varying degrees in the supply. There's so many different types of these substances. I mean, xylazine is only one of them, and they can present with very unclear overdose pictures. So the vitals often don't match up with what you would see in a typical overdose, and they don't respond to naloxone in the same way. And so I guess they're completely different classes, but they both are dangerous, unscheduled, often unknown, but sometimes known substances in our supply.
Perfect. Thank you for that response. And I have one more question. And the question is this drug resistant to naloxone?
Yeah, so the picture on that, I actually haven't been able to see there. I don't believe there's any studies showing the efficacy of naloxone. Some of the case studies I've seen have shown patients requiring multiple doses of naloxone to be able to reverse these overdoses. But at the same time, often these samples are only detected in quite often mortality cases. So cases where patients have passed away and they're in such small doses, and there's very small data on the actual testing of contaminants in the general supply. And so my answer is I'm unsure, to be honest. Yeah, I think there needs to be more studies and more data on that. And that's partially what I'm hoping to achieve through spreading awareness of these supplies. And I'm from what I've read, I don't think that healthcare responders know whether the efficacy of naloxone.
Perfect. Thank you. I don't see any more questions within the chat. So let's move on to our next presenter.
Great, and thank you so much for having me. And if anyone has some contradicting knowledge, please feel free to share.
Thank you so much. Our next presenter is Prableen Sandhu. Prableen is completing her Bachelor of Science at UBC and is involved in the Fentanyl Project. The Fentanyl Project aims to reduce the devastating effects of the opioid overdose crisis. And Prableen will be talking about the overdose crisis with a focus on the youth population. Everyone, please welcome Prableen.
Hi, Prableen. Whenever you're ready, I can start sharing the screen.
Is my audio better now? I don't think you guys could hear me earlier. Are we good?
Yes.
Okay, perfect. Yeah, I can't seem to share my video either. But yeah, I can start whenever you share your screen.
Okay, I'll start sharing the screen now.
Okay, so hi everyone, my name is Prableen and my lightning talk will cover some of the basics of youth mental health in relation to BC's overdose crisis. I'm a third-year science undergraduate student at UBC and the president of the UBC branch of the Fentanyl Project. The Fentanyl Project is a student group founded at the University of Alberta in 2018 with multiple branches across post-secondary institutes in Western Canada, and our collective goal is to mitigate the impact of the opioid crisis through harm reduction efforts such as naloxone training and educational campaigns. North America is driven by increasing toxicity of drug supply, which is severely increasing the risk of opioid poisonings. Today, I will be discussing information surrounding the opioid crisis, largely related to specifically opioid poisoning in youth and youth mental health. This chart breaks down illicit drug toxicity deaths by age group in BC, with people under the age of 19 and between 19 and 29 represented in the lower two columns. People under the age of 30 make up 16% of illicit drug toxicity deaths, and people under 19 only 1%. And looking at national statistics, youth make up a relatively small portion of overdose deaths, especially youth under the age of 19. But why do they make up a portion of these statistics at all? It is beneficial to intervene at an earlier age, as a directed focus on youth amidst the crisis is definitely necessary. Canadian youth aged 15 to 24 had the fastest increasing rate of hospitalizations due to opioid poisonings between 2007 and 2015, and youth also comprised 20% of opioid-related deaths, which provides further evidence for why resources need to be allocated for this particular demographic. And youth have unique treatment needs, with specific risk factors such as peer pressure or stresses associated with discovering one's own identity, academics, family, and self-confidence, increasingly prevalent mental health disorders, and increased likelihood to participate in risky behaviors as well. Many individuals, including youth, first encounter opioids from medical prescriptions, and this is because opioid drugs are the gold standard in pain medication, and young people may be more trusting of doctors, therefore considering prescribed medication to be safer than it really is, and may not understand the risks that are associated with it. The COVID-19 pandemic also led to mental health strain, isolation, and stress among youth, and to top it off, medical services were also harder to access amidst the pandemic. Finally, young people were also more vulnerable due to family stress and domestic violence, which may lead youth to turn to substance use to cope. Youth between the ages of 15 to 24 have also been hospitalized due to intentional opioid poisonings, but accidental poisonings made up the highest portion of total hospitalizations. The statistics displayed on screen also show a significant increase in hospitalization due to poisoning over the years. Government action has been directed at the general public despite its key role in addressing youth specifically and the unique risk factors that were discussed above. Specifically, this could take the form of investments in healthcare services that directly target the young adult demographic, which is somewhat lacking today. The Canadian Mental Health Association breaks reasons behind substance use amongst youth into 4 categories. First, to feel good, providing self-confidence and satisfaction. Second, to feel better, reducing anxiety or stress associated to trauma or depression. Third, to do better by enhancing performance. And fourth, out of curiosity. The brain is still developing through adolescence, making youth especially susceptible to risk-related injuries, including those involving substance use. During this time of critical brain development, 2 things are generally evident: impulsive and risky decision-making, and 2, heightened emotional reactivity and sensitivity. In adolescence, peers become an important part of an individual's network, with peer pressure easily causing youth to use drugs for the first time. Additionally, mental health can be compromised as a result of the unfamiliar challenges of adulthood, and perhaps past childhood trauma can also encourage substance use amongst youth. Some barriers to treatment include difficulty finding information about youth-specific services, stigma propagated by people surrounding a young person, factors such as hospital wait times and rural areas making services physically inaccessible, and there are also unique barriers that come with an individual's personal background. Some strategies to mitigate the impact of this crisis on youth and their mental health are educational programs addressing youth-specific risk factors, service clarity, and more centralized entry points to access services, as well as access to a regulated safe supply of substances when they are needed. Now, on the next slide, you'll see some organizations involving youth directly. Naloxone provides students and communities with opioid education. CSSDP is a youth network concerned with the negative impact of drug policies on communities. The Liam Project is a student harm reduction coalition, and the UBC Student Recovery Community is where students in recovery are exploring their relationship with substances. I'd like to thank you all for joining today and taking the time to listen in. Our website and social media handles are listed on this slide. If you'd like to take a closer look at our past work and upcoming events, and references are going to be on the following slides. I can open the floor to questions with that.
Thank you, Prableen. That was very thought-provoking. I'm just going to see if we have any questions. Okay, I have a question, so I'm going to start off with, as you are the leader of the Fentanyl Project, one of the leaders, what are the future directions for the organization in tackling the ongoing crisis?
Yeah, so a lot of our initiatives focus around harm reduction efforts. So throughout the year you'll see us doing like a lot of naloxone training sessions, and I think a future direction is that we're trying to go towards this trying to become a naloxone kit distribution site. I think there's like some logistical things that we need to sort out in order to do that, but I think across the different branches across Canada, you'll see a lot of naloxone training sites, a lot of panel discussions that involve individuals who are experts in this field. So for example, in the past, we've had a panel discussion involving a psychiatrist that specializes in addiction. So it's a lot of events and fundraisers that are targeted towards not only decreasing stigma surrounding discussions around opioid use, but also actual harm reduction efforts that include things like naloxone training.
Great, thank you. That was a great response. I'm just going to check if there are any other questions. Okay, I don't see any other questions about the presentation. So thank you so much, Prableen, for answering those questions and for that wonderful presentation. And thank you. And I'm actually going to be doing the next presentation. So please bear with me for 2 minutes. And Tam is going to shortly start sharing the slides. Sorry, just one moment. Oh, sorry, Tom, could we restart? Thank you. Hello, everyone. My name is Kovia, and I'm a research assistant in UBC's Addiction and Concurrent Disorders Lab. And I will be talking about how to empower people with substance use disorders in navigating the healthcare system. We're in the midst of a national opioid crisis. According to the Government of Canada, there have been 5,360 opioid overdose deaths between January and March 2022. And this means that there have been approximately 20 deaths per day. Now, studies have found that certain mental health conditions, such as depression, are comorbid with substance use disorders. E-health services have been used to enhance the accessibility of mental health services by reducing barriers such as social stigma, geographical location, and financial costs. Our lab has developed a mental e-health platform, RAMP, for people with substance use disorders. And this consists of various features that helps users in understanding risk factors in managing their symptoms and preventing relapse. Over on this slide, you can see two screenshots of RAMP. On the left-hand side is the screen that you log in, and on the right-hand side are the different educational modules that are incorporated into the RAMP framework. So I have worked on the navigation of healthcare module, and the objectives of this module are to increase accessibility of mental health services by reducing barriers, educate individuals with substance use disorders in a space that they do not feel stigmatized, and empower individuals to have autonomy in their healthcare journey. In this section, we discuss the different types of services available. So physical, which is clinics and pharmacies, mental health services, so it's counseling support groups, and community services. We developed this specific section within the module to highlight services that can promote well-being and mitigate mental health and substance use disorder symptoms while waiting for treatment. So these are the four services that we will be discussing. So we list the crisis line as an important resource as it is accessible 24 hours and it is effective in de-escalating crisis mental states and facilitating referrals to mental health services. Now, RAMP is not a replacement for seeing a doctor. However, skill modules for positive psychology and problem solving can be useful while waiting for an appointment, as they help building mindfulness and developing problem solving skills, which is important for stress reduction. Since we want to increase the accessibility of healthcare services in this module, we discuss applications such as Babylon that can connect RAMP users to healthcare providers, and we also provide info about other relevant apps. Also, some substance use disorders may develop as a coping mechanism for chronic pain. And in this section of the module, we develop how to holistically improve well-being for individuals that have chronic pain. And to address chronic pain in the navigation of healthcare module, we highlight different pain management strategies such as physical therapy and therapeutic exercise. And we also provide resources which can further advise about chronic pain. Studies have also found that chronic pain can negatively impact self-esteem and social functioning. And that's why in this section, we discuss interventions such as CBT that can alter thought patterns. And we also highlight the importance of social groups and support groups. So in conclusion, navigating the healthcare system is challenging for individuals with substance use disorders, and this can be attributed to barriers such as societal stigma, geographical constraints, and financial costs. So this module, the navigation of healthcare module, seeks to increase accessibility for individuals with substance use disorders without geographical constraints, and we establish this in a cost-efficient way. And we also provide a space to educate individuals with substance use disorders without it being stigmatizing, and we empower individuals to have autonomy in their healthcare journey. Now, future directions for RAMP and the navigation of healthcare module include testing it within populations with substance use disorders, and this includes youth and adolescents. And we also want to test RAMP and this module across diverse cultural backgrounds and within urban and rural areas. Lastly, I want to thank Dr. Krause for the opportunity to work on this module, and I want to thank Marcia and Tam. Thank you so much. Okay, I'm just going to see if there are any questions. Okay.
Okay. Yeah, so there are no questions I'm seeing in Hoover right now. But okay, maybe I have a question for you then, Kovia. I was wondering if the platform is now public, or can anyone access it now to maybe test it out or just try it or give feedback? Are there any function like that?
Yes, so we are still in the process of developing certain modules. So those ones are not available to use yet, but people can definitely log into RAMP as certain features are now available. Let me see if there are any other questions. Okay.
Stephanie has a question for you. So, yes, maybe I can read it out for you, Kovia. So one of the issues I would foresee would be distributing this resource and actually having individuals utilize it. What are some ways you are promoting access to RAMP?
That's a great question. So right now we are in the process of testing with super users, and we also want to promote RAMP. A way that I would foresee increasing access would be to promote RAMP within community organizations. And also you can also promote RAMP within religious centers as well. And that would increase accessibility across diverse cultural backgrounds, as that is a place where people, they go weekly, and that would be a great way to increase accessibility of RAMP and to promote it within educational institutions and within community centers. And also have leaders of the community talk about that within members of the community.
Thanks for that. And can I ask which would be the greatest target populations?
I would say RAMP is RAMP, it's quite general. We can use it for various different populations, and it can be adapted to various different populations. I would foresee it being of great use for adolescents and youth, and and other vulnerable populations as well. We can also use it for indigenous individuals as well that are that might be dealing with substance use disorders.
Thanks so much.
Thank you. And I'm just going to check if there are any other questions. Perfect. I don't see any other questions, so we are going to move on to the next speaker. So our fourth speaker is Jessica Michalowski. I'm sorry if I mispronounced your name. Jessica is passionate about raising awareness for the opioid crisis, and today Jessica will be sharing the legacy of her son and will revisit the impact of the opioid crisis on her son's life. Everyone, please welcome Jessica.
Hello. I can't seem to get my video to work, but that's probably okay. Yeah, so my name is Jessica Michalowski, and my son died in August of 2022 from fentanyl poisoning. And this summer, I'm going to be running across southern British Columbia to raise awareness of the toxic drug crisis. I'm here as a mother and not an academic. However, I can provide references for the sources that I use if you are interested. And I'm going to go about a minute over over my time, so I apologize ahead for that. In 2019, I began working on an MA in Cultural, Social, and Political Studies at the University of Victoria on the topic of mothering and the opioid crisis. My son was 23 years old in his second year of Selkirk College's Law and Justice program in the West Kootenays, and his second year of methadone treatment. Despite the challenges of distance education, pandemic isolation, and maintaining a methadone program 50 kilometers away from a pharmacy, in 2020, my son won 2 awards in his program, one in Law and Justice Studies and the other in Restorative Justice. In 2020, I also won an award. I was granted a Shirk Scholarship for research that explores the intersection of popular culture and public health discourses of mothering in the current opioid crisis. I posed as research question the following: does popular perception of drug-related deaths as originating in childhood trauma unfairly position parents, especially mothers, as both the cause and the cure for opioid-related deaths? I presented context for that period. Overdose was then, as it is now, the leading cause of death, unnatural death in British Columbia. I pointed out that fentanyl had been detected in almost all illicit drugs tested by Health Canada. But most importantly, I suggested that despite broadly distributed public health data connecting the recent rise of opioid-related deaths to fentanyl toxicity, popular discourse continues to suggest that those who die are the cause of their own deaths. Such people are constructed as addicted, and increasingly addiction is portrayed as caused by early trauma. I cited a 2018 survey in which non-professionals rated the most likely cause of addiction to heroin as traumatic events early in childhood and the way a person was raised. I presented the research of problematic physician activist Gabor Mate, who, despite good intentions, has exacerbated misperceptions about drug use by attributing drug addiction to brain circuits that develop or don't develop largely under the influence of the nurturing environment in early life. As evidence for his claim linking addiction and trauma, Mate cites the 1998 publication of the Adverse Childhood Experience Study, which correlated abuse or household dysfunction during childhood and multiple risk factors for several of the leading causes of death in adults. I pointed out that a 2019 critique of the ACE framework called it an insufficient and ill-adapted tool, excuse me, likely to stigmatize families and children. My actual thesis veered away from public health discourse and focused on the problems of autobiography as they relate to power and privacy and mothering. Writing about my adult son, specific to his drug use, presented ethical problems for me. I felt guilty about writing about my son, and yet I needed to express the complex experience of mothering during the opioid crisis. And I felt angry that popular culture saw me as the source of my son's problems. I ended up writing a ridiculously complex meta-memoir that placed characters very much like my son and I in a Virginia Woolf novel. I can't believe they allowed me to graduate. Flummoxed with what to do with an unpublishable thesis, I did what any disgraced quasi-academic would do. I applied to a PhD program. I spent a month beavering away on a proposal that explored the concept of the bad enough mother. Most people will have heard of attachment theory, and perhaps even D.W. Winnicott's concept of the good enough mother, which champions the ordinary and sound instincts of normal parents against the encroachment of professionalism into parenting. Few, however, will have contemplated the figure of the bad enough mother. The bad enough mother is not my creation. I owe a debt to Julie Levitt of the Psychoanalytic Institute of Northern California and a short piece of hers that I found that changed my thinking about my experience of mothering during the opioid crisis. Levitt's thesis is that a mother's interpolation of gender is an echoed call to resistance against society's interpolation of mother. In plain English, mothers have been too good, and this too good behavior and identity serves to reinscribe classist, ableist, racist, and patriarchal values. In fact, not only does bad mothering not harm children, but it actually protects them from the essentializing forces of patriarchy and colonialism and teaches them the language of talking back. In other words, ordinary good enough mothering is inadequate to resist patriarchal control. It should go without saying that I differentiate bad mothering from acts of abuse, neglect, or harm to children. Harm to children is child abuse, not bad mothering. Bad mothering can be construed as follows: mothering while being disabled, while being poor, while using substances, while being in recovery, mothering while being brown or Black or Indigenous, mothering while working or going to school, mothering while having a romantic or sexual relationship, while working in the sex trade, mothering while being queer, unmarried, too young, or elderly. My being a good mother could not have prevented my son's death by fentanyl poisoning in August of 2022. He didn't die because I spent too much time working or was distracted by vainglorious ideas of academia, or because I am in recovery from alcoholism, or that I spend too much money and time on being an amateur athlete. He didn't die because I owed $60,000 in student loans or because I was a single mother. My son didn't even die because he was an addict, whatever that is. He died because he sometimes used drugs and he could not evaluate the content and potency of the drug he was taking. I suggest that focusing too narrowly on the causes of drug addiction loses sight of the person who is using drugs, ignores the toxicity of the drug supply, and harms mothers. Instead, I wish we would put our efforts toward stopping people dying. Thank you.
Thank you, Jessica. That was a very moving presentation. I can't imagine how painful that experience must have been for you of losing your son. I'm going to see if there are any questions. Okay.
Kovia, I saw one in the Zoom chat. One question is, can parents access this for support as well?
Oh, is that for RAMP?
Oh,
What is the question?
oh, I believe, yeah, this could be for RAMP.
Yeah, parents can definitely access the module, and we RAMP, and we will probably be making more revisions to RAMP in the future to for it to have different features for parents. So that is something definitely that we could develop within RAMP as well.
But are there any questions for Jessica?
There is. Stephanie just asked a question. So Stephanie said, at the end of your wonderful talk, you mentioned focusing on stopping people dying and the toxic supply. What are some avenues you would want resources to focus on?
Oh, that's a great question. Well, I mentioned that my son lived in the West Kootenays and that he lived 50 kilometers away from a methadone provider, from a pharmacy, and from his the medical team that was assisting him in his recovery. And that distance turned out to be one of the things that I would say indirectly caused his death. At some point, he voluntarily left the methadone program. He was missing appointments. He was probably using other drugs, and that was making his life like a little bit chaotic. He was missing appointments. He was missing going to the pharmacy, and he lost his carries. So I'm not sure if you're familiar with what carries are, but when you're on methadone, you either go in for daily witnessing, right? So the pharmacist observes you taking your dose of methadone, or once you've established kind of a trusting relationship, you can receive up to a week's worth of methadone to take home with you. Well, my son lost that trusting relationship with his methadone provider and was having to go into his pharmacy daily. And I would say that that was a central issue, because in the end, I believe that his being on methadone was giving him a protective factor from reaching out to fentanyl, and fentanyl is what killed him. I don't know if the fentanyl was in some other drug that he was taking or if he took it purposely, but I would say that expanding traditional opioid agonist therapies to reach people in rural locations is super crucial. And that's not even expanding safe supply, right? So that's just traditional therapies. Getting rid of those barriers, becoming more flexible in how we offer those kinds of therapies, I think is really important. And then, of course, providing safe supply of the stimulants and the opioids that he reached out to, so that he could know if he was going to use fentanyl, for example, maybe he decided he wanted to go on a little jaunt, that he could evaluate how much he was taking and what he was taking, because I don't believe he intended to die. He just wasn't able to calculate what it was that he was taking or the potency.
Yeah, Jessica, I think that harps on also sort of my talk on the unknown illicit contaminants in various supplies as well. So those are some really great points on where we could actually allocate resources, especially in the rural areas as well.
Absolutely. My son and I used to joke about a methadone bus, you know, and it could be a bus that went up to those little rural valleys once a day and brought methadone. And there could be a public health nurse there too, who would say, gee, you know, that rash is looking nasty on your hand, or, you know, I mean, I know it costs money, but if we want to save lives, I think we need to start thinking about how to actually create access.
Yeah, that's a really great point. I totally agree.
Thank you, Jessica. That was a great response. I'm just going to see if there's any more questions for you.
I just wanted to add that if people want to follow my journey as I run across BC in May and June, I have social media. Marathon a Day for Safe Supply and is my Facebook, and Marathon for Safe Supply is my Instagram. And thanks for inviting me. This is a great conference.
Thank you for presenting. So thank you to all the speakers for their wonderful presentation. This concludes the lightning talk session. Please vote for your favorite talk, and block 2 starts at 10:30. So feel free to take a break until then. Have a great day and enjoy the rest of the conference. Thank you.